Hello, Psych 101 students. Welcome to Module 7, Chapter 15, Learning Objective 9. We will look at treating bipolar disorder, schizophrenia, borderline personality disorder, and antisocial personality disorder. Bipolar disorders are one of the few psychological disorders for which there is a clear optimal treatment. The best practice is to use psychotropic medications, especially the mood stabilizer lithium, which is a naturally occurring mineral. The process by which lithium stabilizes mood is not well understood, but the drug seems to modulate neurotransmitter levels. However, lithium has unpleasant side effects, including thirst, hand tremors, excessive urination, and memory problems. A newer medication is the drug quetiapine, better known as Seroquel, which is an atypical antipsychotic and is now the most commonly prescribed drug for bipolar disorders, as combining lithium with quetiapine improves treatment outcomes. As with all psychological disorders, compliance with drug therapy can be a problem for various reasons. For example, some people get off the drug because of the unpleasant side effects. Others may miss the highs of their manic episodes and stop taking medication in order to re-experience the mania. However, it has been shown that cognitive behavior therapy can be effective in helping clients to stay on their medication. So it's not enough just to give them medication, but you sometimes have to give them therapy in order to make them well enough to stay on it and to understand that they have to stay on their medication. So let's look at a case study of bipolar disorder. After obtaining her PhD in clinical psychology, Kay Ridfield Jameson joined the UCLA Department of Psychiatry. She had longstanding problems with depression throughout her life. Within months of beginning her job, she began hallucinating and feared that she was losing her mind. She was diagnosed with bipolar disorder and prescribed lithium. Although lithium has helped her, Jameson also credits the psychological support of her psychiatrist, as well as her family and friends. In her 1993 book, Touched with Fire, Jameson makes the point that lithium can rob people of creative energy. It's lithium because it's a mood stabilizer. It really takes away emotional range among people that are on it. They will tend to show very limited emotions. Um, it's I mean it's sad actually, but it's it's better than being bipolar, but it basically holds them, to a very once again a very limited range of emotions. So they're not going to ever get super happy or excited or or really sad. I mean, like it really stabilizes their mood, and so this could certainly interfere with what she called creative energy. Um, um, it's sometimes with hypomania, with limited amounts of mania, it can lead to more creative thinking. Some major artists and writers who may have had bipolar disorders include Michelangelo, Vincent van Gogh, Georgia O'Keeffe, and also Ernest Hemingway. So remember that Prognosis refers to a prediction of the likely course of a psychological or physical disorder. Overall, the prognosis in schizophrenia is not good. Only, one major study found that only about 1 in 7 treated individuals achieve recovery for at least 2 years. So even people that receive our best treatments, I mean, only 1 in 7 can achieve a form of recovery for at least a 2 year period. So it's, for the most part, for most people with schizophrenia, it is untreatable. Although not to say there aren't things that help, such as antipsychotics. Early antipsychotic drugs called conventional antipsychotics reduced the positive symptoms of schizophrenia, such as delusions, hallucinations, and disorganized speech and behavior, but these medications have little to no effect on the negative symptoms. Just to back up a little bit, when I was talking about prognosis, and one other point I wanted to make was that the prognosis for people with schizophrenia depends on the age when the disorder first appears. People who are diagnosed later in life tend to have a more favorable prognosis than people who experience their first symptoms during either childhood or adolescence. Okay, so back to the conventional antipsychotics. As I mentioned, they're good for positive symptoms, but do almost nothing for negative symptoms. And also, they can cause a really terrible side effect called tardive dyskinesia. It's a permanent side effect that can result from the use of conventional antipsychotics. So permanent side effect means like you can get off the drugs, but the tardive dyskinesia doesn't go away. Symptoms for tardive dyskinesia include grotesque, involuntary movements of the facial muscles and the mouth, and twitching of the neck, arms, and legs. It is a very severe side effect. We can see a picture of a guy here that has tardive dyskinesia. And on the right side, they're looking at the effectiveness of conventional versus atypical antipsychotics. So far, I've talked about the conventional antipsychotics, and you can see in the picture they are the yellow lines. So you can see that the conventional antipsychotics are somewhat effective in reducing positive symptoms by a little bit, and really not at all effective at reducing negative symptoms, as shown in the second diagram. But the atypical antipsychotic drugs, as you can see, reduce both positive and negative symptoms, and they do a much better job with both types of symptoms compared to conventional antipsychotics. So let's take a closer look at the atypical antipsychotics. They act on different neurotransmitters compared to the conventional antipsychotics, and they are beneficial in treating both the positive and negative symptoms of schizophrenia. Atypical antipsychotics, however, can have serious side effects, including seizures, heart rate problems, and substantial weight gain. And some of these drugs can even cause a fatal reduction in white blood cells. There are some newer versions of the atypical antipsychotics that are somewhat safer, but they may not treat the negative symptoms as successfully. Um, Whether we're talking about conventional or atypical antipsychotics, so understand that they are certainly not a cure for schizophrenia. They reduce symptom levels, but the person still has schizophrenia and it will still be affected by it, even when they are on these drugs. I can tell you, um, I did enjoy when the times when my sister, my schizophrenic sister, when she was on antipsychotic medications, she did appear more normal. It was easier to have conversations with her, and however, one of the problems with schiz people with schizophrenia is that they rarely admit that they have a problem. I mean, in 30 years of my sister having schizophrenia, I mean, she has never once said that she is sick in any way or has any illness or disorder. It's very hard to get treatment for her, and um, because and so when she's on medication, if there's any side effects like weight gain or something, she usually stops taking the medication because she doesn't really feel like she needs it anyways. We noticed a difference, but for herself, I mean, they, she, she doesn't believe that it's necessary. Um, and this is a typical problem. A lot of schizophrenics, they don't like taking drugs that have been prescribed to them, and these drugs might be used to control them or to, they're because of their delusional thinking. I mean, um, they're very hesitant to do things like take medication. Okay. Behavior therapy can include social skills training to elicit desired behavior, such as appropriate ways to act in specific social situations. If a client's self care skills are poor, behavioral interventions can focus on areas such as grooming and bathing, managing medications, and financial planning. So, what they're saying here is that, they do use behavior therapy with schizophrenics, but once again, they're not curing the schizophrenia. They're just helping them to live with it. So teaching them how to act in certain social situations, for example. It's very hard for a person with such schizophrenia, like my sister, for instance, to hold a job, even though she's still intelligent. I mean, but at some point she'll start saying, crazy things and or accusing her boss of something or whatever. And it's hard. It's even hard for them to hold residences. I remember she was in one place for a little while, and she became convinced that her upstairs neighbor was coming down and cutting her hair during the night. So she called the police on her and everything. So it's at some point, it's often they will lose opportunities as far as a place to live or if they manage to get a job because their delusions of can will get in the way of normal social behavior. Um, okay, let's. Traditional psychotherapy approaches have been largely unsuccessful for treating borderline personality disorder. The psychologist Marcia Linehan pioneered, and you should know that name. Sometimes it may show up. It could possibly show up on a test. So Marcia Linehan, Line, like line, and HAN, Linehan. Okay. So anyways, she pioneered the therapeutic technique of dialectical behavior therapy, or DBT. This is a form of therapy used to treat borderline personality disorder that combines behavior therapy, cognitive therapy, psychodynamic therapy, and a mindfulness approach. So in phase one of DBT, the client learns to change extreme behaviors by using mindfulness to focus on the present and to improve problem solving and coping. In phase two, The client explores past traumas underlying her emotional problems. And in phase 3, the client works to increase her self-esteem and stops depending on others for validation. Okay, let's go on. Treating people with antisocial personality disorder, or APD, often seems impossible. Individuals with APD apparently have diminished cortical arousal, so stimulants have been prescribed to normalize their arousal levels. These drugs are somewhat beneficial in the short term, but not for long-term use. Other drugs have also been tried, but psychotropic medications have not been effective in treating this disorder. Most psychotherapies also seem ineffective in treating antisocial personality disorder. One of the reasons is that there is a great deal of difficulty in developing the necessary therapeutic relationship with an individual who has antisocial personality disorder. Psychotherapy approaches, as I mentioned at an earlier point in an earlier video, one of the things that it depends on is a belief in the therapist and belief in the therapy. Like the therapeutic relation is an important part of therapy, and this is difficult to achieve with somebody with antisocial personality disorder. However, providing reinforcement through operant procedures can increase desired behaviors, as shown in the example in this picture. So they provide reinforcers for desirable behaviors, such as taking classes while in prison, and and this leads to an increase in desirable behaviors. This, however, only works when the client cannot leave treatment and is part of a group. For example, when they're residing in a residential treatment center or in a correctional facility, like in this example here. Otherwise, somebody with APD, if they're not being, if they're not being forced into treatment, they don't voluntarily show up. So the only time you get any kind of results is when they basically have to take the treatment because they're in a facility and can't leave. So as I was saying, their behavior therapy approaches using operant procedures, as we just looked at, have had some success in increasing desirable behaviors in treatment facilities or correctional facilities. But overall, the prognosis is poor that clients with APD will change their behaviors as a result of any form of therapy. Fortunately, individuals with APD typically improve after age 40 with or without treatment. For example, criminal acts and imprisonment decrease among those with APD after the age of 40. You can see in shown in this longitudinal study here that it was comparing a group of subjects with APD compared to a group of subjects without APD. And it was a longitudinal study stretching from their teenage years up until their 40s, where they followed the same group. And this graph here shows how likely, like what percentage of each group of subjects were in prison, during different age periods. And you can see all the way from the teenage years up to around 40, the people with antisocial personality disorder were always more likely to be in prison. However, you can see as you get to the final age group, 41 to 45, there's a dramatic decrease in the proportion of APD subjects that were in prison. And and this is just one study showing this change that happens as a individual gets into their 40s with antisocial personality disorder. And we don't understand it well. Um, there may be some natural biological changes going on in the brain, but they tend to um, they tend to slow down their criminal activities and behaviors, and they don't be. I don't think they ever become great people, but but they're less of a danger to society after they reach their 40s, at least a little bit. Okay. Um, and I think that will do it for learning objective 9.